Hi, my name is Daniel Avisar. So I'm a brain injury survivor, and I just wanted to introduce myself. Since my brain injury that happened when I was 18 years old in 1999, I feel like what I've been dealing with has never really been understood by the people around me, unless, of course, they've had a brain injury. And if they've had a brain injury, although no brain injury is the same, there's a lot of commonality, a lot of these interesting parallels that come across when I get into discussions with brain injured people. But in general, because I feel like unbrain injured people don't understand what I'm dealing with, I've tried to work on this seminar series, the Building Brain Awareness to help support what I do. Building Brain Awareness to help support brain injury recovery is a talk series about information, talks, neuroscience specific, and also clinical application for brain injury. And I find these talks that are very helpful for helping people make more sense of what kind of aspects brain injured people have to deal with. I go to a lot of talks, I go to a lot of different seminars, and not all of them are good, but some of them are good and some of them are very, very good. So a few years ago, I saw Dr. Karen McAvoy. She was giving this talk as part of a larger seminar. She was speaking about very specific stages, the fatigue stage, then the slow mental mud stage, and then the memory problems. And she had said that in her clients, she had been working with clients for about 30 years, and she saw this similar progression across her clients. And she spoke about these stages as well as how the outside world didn't understand what these people were dealing with, and they were constantly misinterpreting, misunderstanding, judging what the people were dealing with. And I found this information which she had to share very significant, because not only did I go through those stages as well as others, but she's the only unbrain injured person that I've ever heard talk about these stages. And as soon as she spoke about it, I was thinking, okay, she knows something that other people don't. I have had these problems in the first 7 years of my brain injury. I had about 8 different minds, drastic changes in the way my mind worked and my head worked, and it was all internal and it was all hard to explain. And the only other people I've ever met who even talk about these things are people with brain injury. Usually they're in one of the stages, and maybe they've transitioned maybe from the fatigue stage to not having the fatigue as much, or they're in the mental mud. It feels like the gears of your head are not working, or if they work, they're very, very slow, like you're in a swamp. And then when that stage happens or passes, if it does pass for a person, then the unique memory problems. I know many people have memory problems, and it's a problem that doesn't, it's not only unique to brain injured people, but the memory problems with brain injury are pretty unique and pretty specific. So anyway, I got talking to Dr. Karen McAvoy, and I asked her if she can give this talk, which is more about the things that are underneath what the outside world sees, the problems that are underneath the other problems, which is unique to brain injury. And indeed, she had a perfect talk for it. So this is that talk. And I have more ideas to share. I'm going to share them at the end. And I broke this talk into 2 parts. First, there's the actual presentation, and I'll share a few thoughts at the end of that. Then the second part is the Q&A and the discussion that follows, which a lot of really good points come up in. And I think that this is the best talk that I have ever seen towards helping people understand what brain injury is about, or what kind of problems people have to deal with brain injury. The model that Karen explains is very consistent with my views of how brain injury problems are, where you have problems underneath other problems, and you don't really have the ability. People don't understand what these problems are, because they are what actually got injured in our brain. And so the model that she's going to explain is really consistent with the views that I have. I've been using the term core problems, and what she shares is very similar to that idea of core problems. So with that, please enjoy this talk. Please share it with anyone that you think it may help. And also, please check out the other Building Brain Awareness talks, as well as my podcast called Experiencing My Brain, where I get into in-depth discussion with other brain injured people about their experiences and what they are, experiencing relative to these problems within themselves. And although not every brain injured person knows exactly what is wrong with them. We do have an awareness, and we do have, you know, an awareness of the broken brain parts within us. So, thank you.
So Dan talked to me this morning about just giving you a little bit of background on who I am, and then not really spending a whole lot of time on brain injury, the mechanics of it, because you know a lot of that already, but jumping into some of the more specific areas of cognition and how kind of a model that we use here in Colorado and being used in other places, to work on building up those strategies and through recovery. And so let me just start with telling you who I am. I am both a clinical psychologist and a school psychologist. I've been practicing for about 35 years and did my training in pediatric and adult medicine, behavioral medicine, where we are working with people who have medical conditions, but we're working on the psychological side of it, the recovery piece, the mindfulness, the spirituality, the relaxation, all those other things that can either make medical recovery go better or can slow down and impact it. And then when I had my own daughter, who's now 30, I decided that I no longer wanted to be in the hospital, doing, call and there all hours of the night, and could no longer do that with my own baby at home. And I left the medical field and went into school psychology for about 20 years. And as long as she needed me while, she was in school, then I was going to have that same schedule with her. We'd be off for the summers and off for fall break, winter break, and could be done at 3:30. So I went to work as a school psychologist in Cherry Creek schools, but my love for brain injury was just always there. And in the mid 1990s, the federal government started moving forward with brain injury teams in schools, and I was asked to lead the one that we had in Cherry Creek. And so I was able to kind of get back into my love of brain injury. And then in 2004, I was still working in the schools. I was the psychologist at Grandview High School, which is a large high school in Cherry Creek School District, where we were doing a study for the Center for Disease Control on the baseline test called the impact test, which was developed for the professional football players. We had just baselined our first group of freshman football players in September of 2004. And we had a young football player named Jake Snakenberg. He went down with a concussion. He was put back to play a week later. He went down the second week in a Saturday freshman game, was airlifted off the field, taken to a hospital, and he passed away the next day. So that became our case of second impact syndrome here in the state of Colorado. It became our law, and I ended up writing a community-based interdisciplinary team approach to concussion management called REAP, which stands for Remove, Educate, Accommodate, and PACE, which are the 4 steps that schools need to understand about concussion management. And it's a color-coded manual. It has 4 teams. It talks about what each team needs to do, including what the parents do, including what the medical provider does. But the school has to have 2 teams, which is the school athletic team, if it's an athlete, and the school academic team, because we have to keep all kids learning. So REAP became something that became the way that we managed concussions in the school that I was at, in the district that I was at. And then eventually in 2010, I was approached by Rocky Mountain Hospital for Children and asked to go and to leave schools and go to the medical side again and open the Center for Concussion and treat kids with concussion and brain injury through Rocky Mountain Hospital for Children, which I did for 10 years. And REAP was our model. REAP has now been customized in about 17 different states. And it's been, brought to Congress. And so it's been a great way to try to get everyone on the same page. And it's free in most states that have brought it into their states. something that parents and schools can download for free and get some support on how to manage concussions so we don't miss another case and have a case of second impact syndrome. And then right at about the beginning of 2018, I left Rocky Mountain Hospital for Children for kind of partial retirement, moved to Fort Collins, where it's a smaller town north of Colorado. And I am working in a clinic here called the Asha Brain Clinic, which means hope in Hindi. I work with a Dr. Mistry, and we see primarily adults and some kids with brain injury, primarily motor vehicle accidents, primarily Medicaid and Medicare. And we have a whole team here of occupational therapists, physical therapists, speech language, and it's just been wonderful to work with this very integrative group on getting people who have had injuries currently or injuries that were never really treated fully because we didn't know what we were doing way back then, and getting them through kind of a more integrated approach to rehabilitation. So it's been great, and we're 5 years into that now. So that's kind of my background. And I'm going to skip a lot of these slides in here because it's about the background of brain injury, which we don't really need to go into. And I want to show you the model that we're using here in Colorado in this clinic, as well as at the Department of Education. So hold real quick here, and I'm going to quickly zip through these slides. And
Karen, can I ask you a question? And
yes,
also,
please.
I wanted to say, and I should have said it earlier, the stages that you spoke about at that talk that intrigued me was the overwhelming fatigue stage, then the movement, the mental movement, like your head, like everything is gears that don't turn, or walking through mud. Swamp is how I've heard other people describe it. And then the last phase, when that went away, was memory being a problem.
Okay.
Do you still see those
Yes.
trends across people you work with? Yeah.
Yes, I do. And in fact, in this clinic here, where we're primarily seeing adults, not just concussion, but more concussion as well as more severe brain injury, that pretty much is what we see. And the order in how we do our rehab does still follow those stages. So I think I'm on track with you now, Dan. I don't know that I have it written in here, but
can I ask you a question?
Yes, please go ahead.
You mentioned when you started out that there was some young fellow, I think he was playing football, he had a concussion, what you called second something syndrome. He died?
Yes, second impact syndrome.
Right. So he was playing football, he had this concussion, and after some period of time, he went back to playing football?
Yes, that's exactly right. He went back.
And whose decision was that? Was it his?
No, not his. So
Well,
yes.
therein lies the fallacy of all of this. Okay, it is sheer stupidity, pure and simple. I've done a lot of work around healthcare, and I'm at the point where I am pretty much fed up with the entire system. That there's just so much stupidity that goes on.
Randy, stupidity is a problem. Also, ignorance and the fact that they don't know. And there's a culture in most sports.
It's kind of like with the NFL, okay, where they think they're going to come up with a helmet that is going to somehow protect people, and it's not. It may end up reducing the impact of the injury, but nothing is there is no device that is going to prevent your brain from being jostled around inside of your skull, which has a rough interior, and at the very minimum will create cellular shearing and tearing.
Yeah, that is true.
Randy, that's part of what she's trying to talk to us about.
Right.
Yeah.
So why in the world would you take somebody that was injured, particularly somebody who's younger, and allow them, if they're
the
weak,
reason she's doing this work is to stop that and to educate people. So
and also they didn't know. They didn't know back then, and they didn't think about it. And in general, people without brain injury don't even think about it. Twice in this last year or two, I've heard people talk about the evolution, the changes, and so we're here to talk about the changes in much more detail. But yeah, it's a ridiculous oversight and mistake, and yeah.
Okay.
Yeah, you're absolutely right, Randy. And let me.
I guess I misunderstood you in the beginning then.
No. I am with you on this. We wrote REAP to try to stop this craziness that goes on. However, I have to say, 2 decades into it, it's still happening. People are not necessarily going through the protocol that you need to safely put these kids back. And because I wasn't really asked to talk about that, I can. Dan, if you ever want me to come back and just do a talk on the criteria for recovery, but I'll touch on it real quick here, Randy, and then I'll go into this other part here about the cognition. You're absolutely right. What we learned when Jake passed away and what I wrote up in REAP, and if any of you want to download REAP, it's just REAP concussion singular.com, and you can find it and download it. What we wrote up in REAP was because the adolescent brain is so vulnerable that if you take one hit to the head and then you're still symptomatic and you put them back to play and they take a second hit to the head, that second hit to the head can be catastrophic and lead to brain damage or death. And it's happened in most all states. In our state, it happened to be death with Jake Snakenberg. So when we wrote REAP, we said, you have to have multiple eyes on these kids. You can't just let them say, I'm ready to go back. And in 2004, nobody knew anything about concussion. But what has happened since is we all now know that you must have multiple players watching these kids. When you have a medical provider, you need parents knowing what they need to know to be watching for. You need to have teachers watching, coaches watching, and there needs to be a consensus decision about when is it safe to put a kid back to sport. In Jake's case, he was put back to sport within a week because at that point we didn't have protocols. His dad is a cardiologist, his mom is a transplant nurse, and they still didn't even know what to look for then. So he was put back in a week, took a second hit, and then this catastrophic thing happened. So that is why we all moved forward with the protocols in every single state about how you safely put a kid back to play. I won't say that those are being followed 100%, but the REAP protocol will walk you through those steps, and we try to stick to that. And Randy, if you want to download that at reapconcussion.com, you'll see all of that. And I'm sorry, I didn't really pull together a talk on REAP today, but I can definitely do that another time if you guys are interested.
Okay.
I'm talking more today about cognitive. So going on, let me introduce this model to you. Okay, so this is a model that we came up with at the Colorado Department of Education. And the reason we have come up with this is because we as clinicians, we as school providers, we didn't want to get into this, what happens in the world of brain injury, which is, you need to be a neurologist to know the brain. You need to be a neuropsychologist to know the brain. This myth that there's only a few people out there and few disciplines out there who know the brain well enough to help people who have suffered a brain injury. And we as educators, we have, kids who suffer brain injuries all the time. And now I work in a clinic where we have adults who suffer brain injuries all the time. And this sort of myth of, if you're not of that discipline, you can't be helpful to these people. And we did not like that. We wanted to be helpful. But we had to get away a little bit from the idea that we need to know exactly where in the brain the injury is, and then, only a certain person can fix that. What we tried to do with this model is to make this much more person-friendly, educator-friendly, parent-friendly, so that we all can jump in and support anybody with a brain injury, because these are skills we all know how to support. So let me start first with just explaining this model. The brain basically develops in this bottom-up model. The things that develop in infancy and childhood are going to be what we call the fundamental skills, which are memory, processing speed, attention, inhibition, which is the ability to stop long enough and make a better choice, and sensory motor. So if you think of young children, this is what they're working on in the beginning, just paying attention, following where their mom is. Eventually, when they become toddlers, they're, learning to wait if they're hungry, they're crying, but they have to wait until the bottle gets warmed up, that kind of thing. And so these fundamental skills develop first in a brain. And then eventually what builds on top of that are things like going to school, learning language, learning reading, writing, and math, and visual processes. So you can see the second green level is what we call the intermediate processes. And then eventually what builds on top of that are what the blue level, which we call higher order processes, which is social emotional competency, which is, being able to know when it's okay to tell a white lie, manners, being polite, all of those things. And then executive functioning is the other thing here, which those are many of the things I think you had a speaker talk about earlier. That's like organization, planning, initiation, problem solving, judgment. Those are the things that really lead into our personality. Those are the higher order things that tend to kind of come from the frontal lobe, but they have to do with how well are we managing life in a social, emotional, multitasking way. And then finally, on top of all that is the person who is just well put together. It's achievement, it's their job, it's how they do at school. And if everything underneath is pretty well put together in the brain, and there's been no injury, this is how the brain develops. And this is a pretty well functioning person. So this is the model that we go with now. What ends up happening with a brain injury is that you start with these skills. A baby is born with these skills. You all were born with these skills. I'm born with these skills. But what happens is, with a brain injury, if one area gets knocked out of place, and you probably all know that attention is probably one of the most common things that gets knocked out of place, whether that's with a 3-week concussion or a 36-year brain injury. These fundamental skills are the first things that get knocked out of place. And when that happens, so attention is sort of temporarily or permanently not as strong as it was before, what happens to the rest of the skills on top of it? They fall in, they collapse in. So learning might be harder for a child who had a brain injury. Language might be harder. But what really people come to us all the time saying is that this person's personality is not the same. This person's not making good choices with social emotional things. They're, asking me inappropriate questions. This person doesn't have executive functioning, meaning they're not organizing as well. They're not multitasking as well. They're not functioning as well. They don't have as good judgment. And they'll come to me as a psychologist or some of my colleagues and say, this person with a brain injury has these issues. Everything looks fine with them in terms of cognition, in terms of, an IQ score or something. Yet we have these skills that are not working so well for them on the social emotional executive function part. And then they say, fix those, make that person stop asking that question, make that person, behave better, especially with kids. I get a lot of this, make that child behave better. And that's the reason why I love this model, is because we now know as educators, and I know as a clinician now in this clinic that I work at, when someone says to me, make their executive functions better or make their behavior better, I don't go straight to try to fix executive functioning. What I look at is, where is the deficit that I can fix and work on? And that's what we work on cognitive rehab. If I can drill down to it's an attention problem, then if I work on attention, I can strengthen language and learning and social emotional and executive functioning up above that. And that's how those things get better, not by simply telling them, to do better in those areas. One of the most common things I see with kids is that attention and inhibition are very closely related. So Inhibition is that inability, you're so impulsive, you don't stop long enough to consider a better option. And so what ends up happening is for a kid or an adult with a brain injury, they may act upon an impulse that they didn't stop and think through all the way. And then it looks like a bad behavior. And so then what teachers will say to me, or parents will say to me, or a spouse will say to me is that behavior is not okay. And therefore, they're seeing it as a social emotional competency problem or an executive dysfunction problem, when it's likely an attention or an inhibition problem. Or people who are working with a probation officer and they forget to show up to their appointments, the probation officer will say, well, that person is violating my rules, when probably it's a memory problem. And so most of the issues that people come to me with brain injury that are related to brain injury, they look like a behavioral problem or willful disobedience or arrogance or, neglect. And really likely it's a fundamental skill where they're trying very hard to remember, but they forgot, or they're trying very hard to pay better attention, so they're focusing more, and to stop impulses and to choose a better choice, but they just didn't get there. And now, it looks like some kind of bad behavior. So we go with this model because it allows me as an educator, as a clinician, to intervene and to work with people instead of just throwing up my hands and saying, oh, I'm not a neurologist, I can't help people with brain injury. Or throwing up my hands and saying, oh, well, this is just bad behavior, which is what I get often from teachers and parents. This is a skill deficit, not a will deficit. This is a can't, not a won't. And I teach that all the time, can't versus won't. So
Can I
yeah,
just add, what you're saying is like, I've had detailed discussions with every single person here that I've talked to. So yeah, we're all on that same page so much. I call what you have in these boxes these core problems that we get injured. And I think like if you throw a dart and it hit anywhere here, people here would be like, yes, I've been dealing with that. I'm trying to build an awareness of it. And then
right.
the symptoms, the lack of understanding, the outside world observes the behavior is a constant misunderstanding and frustration that we're all dealing with. So we're fully on this page.
Exactly.
just to say.
Okay, that's good to know. What I'm trying to do with this model in Colorado, and I travel the country and train to this model, is to get your healthcare providers to understand this as well. You know this, but the lens that parents or teachers or rehab specialists might see behavior is a different lens. And it's not that we are just trying to get them to see it from this lens, because how you treat a behavior that is a can't, you teach, versus a behavior that is a won't, you discipline. And so we want just everybody to be on board. And it's not just brain injury. I mean, kids with, other trauma or the other things will also present the same way, where people will tend to jump the gun and say, oh, that's a social emotional or executive dysfunction problem, bad behavior, when it could be something lower level like attention. They didn't get your instructions. They didn't understand the cues on the playground. So therefore they grabbed that ball and they ran with it. So I'll go into a little bit more on this model. I just want to sidestep for a minute, Dan, and talk a little bit about what you were talking about earlier.
Sure.
Well, when I see someone with a brain injury, the first time they come in the clinic, the biggest overwhelming problem that they are that gets in our way is that they're fatigued. The symptoms are high. So basically our model in the clinic I work at now is, when you have a brain injury, it is an energy drain. It is an energy drain primarily coming from your eye tracking issues or your vestibular inner ear issues. We call those primary processing therapies in my clinic. This is just our own language. I don't know that it's out there with everyone else, but someone with a brain injury will come to us And when I do testing in the clinic, what I will probably mostly find is that their attention scores are very low. They're having trouble concentrating. They're having trouble with memory. They're having trouble with processing speed. So everything is slower, everything is harder, everything takes more time. They're having trouble with sensory motor, light, sound issues. Everything is overwhelming. And they can't sometimes, so these issues that we're seeing in the orange level here, the fundamental issues that we see in the beginning in a brain injury, are generally because there's an ocular motor or a vestibular inner ear problem, a primary processing problem, where the brain, it's not what you can see or what you can hear, but the brain is getting mixed messages in the brain, and it's not giving out good messages. So in the clinic here, the first thing that we tend to refer our folks to is a primary processing therapy. It's either going to be occupational therapy to work on the ocular motor issues, or vestibular physical therapy to work on the inner ear issues. Because if you're in pain, if you are feeling foggy, if you are feeling nauseous, and you're feeling dizzy, you will not be able to access memory, processing speed, attention, sensory motor, all those things. You're just overwhelmed with all of it. Your symptoms are high and you're fatigued. You're just drained and on empty all the time. So these skills can be less efficient because of that. Once you have worked a little bit on your ocular motor and your vestibular issues in primary processing, then you'll start to find that your memory, attention, processing speed secondarily gets better because you just have more energy to deal with it. And also you'll find that your language, your learning, your decision making with executive functioning, organization, all of those things get better as well. But if they don't, then we go to cognitive rehab. So we go in that order that you were talking about, Dan.
May I ask briefly? Mm-hmm. It sounds like you keep saying two things, ocular and inner ear thing, and I keep thinking I'm missing another one. Are you talking about primarily two systems? Primarily
two, ocular motor and vestibular.
Oh, okay, thank you.
So ocular motor, the eye, and the vestibular in the ear, 95% of everything that comes into our brain comes in through our eyes and our ears. So you can imagine if the brain injury has in any way impacted the input into our brain through our ears and our eyes, it's going to be kind of, garbage in, garbage out. We struggle because then we're not clear, and it will impact memory, processing speed, and learning and decision-making behaviors and executive functioning. So the first thing we want to do is make sure, as my doc that I work with here says, we clear the deck. We want to make sure we get the primary processing issues worked out so that the brain is having as much advantage to understanding everything that's coming in and it's not garbled. And then these will strengthen up a little bit.
Can I ask a question about this?
Yes. Mm-hmm.
I imagine that you assess each client's needs for those specific therapies. What you're describing is something I've been calling the hierarchy of problems. I had double vision due to cranial nerve injury, so I would have needed something very specific. But that overwhelmed everything else. Like I remember experiencing, I can't even do these other things. And Nancy can share about you, Nancy, if that's okay, about your CSF stuff. She had inability to have the brain juice flow, and until she dealt with that, and this is
totally.
I imagine there's other versions of this beyond these two therapies.
Totally. The biggest culprit that we see is going to be with the eyes and the ears, more like yours, Dan, at the double vision. If you have double vision, then you can just imagine how confusing and discombobulated the world can feel. And then
I don't need to imagine. It took about, I got into therapy, it took about 8 months, but it was the most overwhelming thing, and it was constantly so yes.
Yeah, exactly. I have a family member who had vestibular inner ear issues, not from a head injury, but just perimenopausal kinds of things. And she always felt like when it was 8 o'clock in the morning, she thought it was 2 o'clock in the afternoon. When she was in the shower, she felt like the shower was moving in and out. I mean, yes, you can get these conditions from other things, but they're very common after any kind of a brain injury. But you're absolutely right, Dan. Besides those, having any kind of blockage with your arteries and blood flow to the brain, all of those things are going to change your cognition, and it's going to make you feel like you're walking through mud. Everything is harder, and you can't access these things. But the way it manifests and people see it is often like you're irritable, you're not making good decisions, you're snappy. And so it comes out as a behavior problem rather than as a skill deficit on a lower level here, on the fundamental level here, which is something that we can rehab and try to make you feel better. All the rest of it will get better. But in the meantime, we need patience from other people out there to not see it as a bad behavior.
Karen?
You're talking to a person here who's had to deal with this for 35 years and is half blind as a result of this, and is, as I'm getting older, and I've had to become, work through, a person who had SSI and then worked through life, Social Security disability, because, the system. But through the whole thing, I've been half blind and half, very unbalanced, and as I've gotten older. So it's tough to try and through therapy, because what you're saying is, kind of not really, it's something I deal with every single day. It's not like therapy through it. The therapy is an everyday thing. So
Right.
everyone here has that 100%. And so I'm glad. I have only seen one non-brain injured person talk about this. That's why that's why Karen's here. It's really weird. It's really, really frustrating. Yeah.
This is the thing that's going to be there forever. You're doing therapy every day. It's not like a therapy is going to go disappear.
Exactly. It's going to be try to remediate what you can, try to compensate what you can, and then take a break from it for a while and eventually come back and work on it again. Because you're right, there, depending on the severity of why these skills get knocked out of place. If I'm talking about a concussion, then I hope that a couple weeks of therapy is what's going to bring that attention back down again. But if I'm talking about something that is more structural, and there's something that is, cannot be fixed from a structural standpoint, then that attention or what else gets knocked out of place is not necessarily going to come back in. So then we compensate. So as my doc here that I work with likes to say, he likes to clear the deck, figure out all the possible structural and medical reasons why things are not where they need to be, and then plug the holes. And that's what the different areas.
You mentioned something about doctors being like not a part of like giving you they're afraid of us seeing what your x-rays are like and what you're feeling, if you're going to be afraid of. It's ridiculous to have a doctor be, let you see I don't know how to say this, but you know more about your injury than any doctor there is.
I would agree with you, Roscoe.
Yep. That's why in our clinic here, I do some very short neurocognitive testing where I'm only looking at these areas. I want to see where memory, attention, processing speed is. Takes me, it takes basically 20 to 30 minutes, an hour maybe. I also ask people functionally, how are things impacting you? I benchmark that at the beginning of rehab. And then we start OT, PT, whatever the therapy is that the doc feels would help with some of these things. And then I'll test again, probably 3 or 4 months down the road, functionally, as well as just in these areas to see if things are getting better, kind of like our lab work. And that directs our treatment. We don't do full neuropsych testing here. We don't do 10 hours worth of neuropsych testing here. And what we do is very functionally based, because you're telling us what you want to work on. You're telling us where things are a problem. And we take you at your word for that. We're not trying, we're not looking at all those other things. So let me go a little bit further with this. So what we did with this model, now that we've established how it works, is we built these building blocks. And then what we did is we assigned the correct assessments that go with it. So when I talk about the correct assessments, I mean like a part of a test. not a full neuropsych test, but one part of one test will pick up attention. One part of another test will pick up processing speed. Those things might take me 20 minutes to do, not 20 hours to do. So we're looking for really specific areas, and then we assign strategies for those. If we drill it down and find that we have an issue with processing speed, well, here are strategies for processing speed to increase processing speed so that we can move beyond just we know there's a deficit. We know that there's an issue. We can see that on a CAT scan or whatever imaging. We know it's affected you in certain areas. It's a skill deficit. But now let's work on how we can make those things somewhat better. Not all the way better for some people, but, begin to move forward instead of just throwing up our hands and saying, well, we're not a neurologist, so we can't help people. So what we did is we took these same blocks and then we drilled them down to parts of tests that are going to give us that information. And that's all on this website here, codekidswithbraininjury.com. And so my educator colleagues, we're supporting them on doing these assessments, not waiting for neuropsychologists because we don't have that many neuropsychologists in town and because people can't afford neuropsychology basically, and it's not repeatable. So we do these testing in schools. And this is the codekidswithbraininjury.com website. It's all free. You guys can look there. And then here are the strategies. If we find that there are some issues, let's say we're working with a kid with a brain injury in a school and they have some attention issues, then we're going to work with them in school on this program called How Does Your Engine Run, which is an attention thing. So basically we take these and say these are skill deficits. It's not bad behavior. And we start to move them forward. This is the 104-page book of interventions that we use in schools to help kids with brain injury start to rehab these areas and move away from teachers and parents who are saying, this kid just will not give me the behavior I want. We don't want that. We don't want them to see it as a won't. We want them to see it as a can't, because a can't, we will try to do interventions and teach. So the areas really quickly, and we probably don't need to go through this in much detail, but attention and inhibition, you can see they're all orange. These are the fundamental skills: memory, processing speed, and sensory motor.
There was a question, and I also had the question. So you do get into the vast complexity of each box has so much more to it with attention, with.
Yes.
Yeah.
Yes. There are different kinds of attention. You're right. Yeah.
And are there other levels? Like I was thinking about auditory processing versus visual. Like, do you guys get into that if needed?
We can. It just depends on how much testing you want to do, and for what's the reason for your testing. If you're a neuropsychologist and you're trying to get into all of these because you're going to court, maybe, yeah. For me in the clinic, I see patients all day long. I don't really need to go into as much detail. And I want to see a patient, get some quick testing so that I can get them over to rehab. I can get them getting their interventions. So I just do the kind of testing I need to do that basically is like our lab work. And then we test it again in 3 months and say, okay, yeah, that's come up. So obviously we can't, we don't want to put people through too much testing.
Got you. You have to get them to, yeah.
Mm-hmm. So, but if you're going to court or you're going through neuropsych testing, that's going to be very deep and very long and expensive. So basically, those are the different entities. All right. For example, what ends up happening is that a mental health or a behavioral crisis will happen, and they'll come to me as a school psychologist or as a clinical psychologist and say, this person, let's say this kid, who had a brain injury, he took off in the car and he wasn't supposed to. The parents come to me and say, that's really bad behavior and very poor judgment. So it falls within this blue area. But when we're looking at brain injury and we're looking at teenagers, we're trying to figure out everything. I mean, is it the brain injury that caused that? or is it anxiety, or were they, exploring with, drugs? And so you have to look at the whole picture, right? This 15-year-old who got an adolescent brain. And if I drill it down, I might find that this 15-year-old is having some attention issues, which means that they didn't have good inhibition, made some bad choices, and they couldn't remember, what the rules were. And so if I start to look at where this might have come from, it might not just be here on this blue level. It might be something that's lower that we can start to work on. Because when these things get knocked out of place, we basically, what is social-emotional competency? It's being able to use the feedback to make better choices next time and not do the same thing over and over. What is it? Executive dysfunction. It's the inability to think through all the consequences. So if you have a kind of a shaky foundation, you're going to have those other areas fall in. So what we're always working with parents and teachers and healthcare providers is this a can't or is this a won't? And if it's a can't, we can train, we can teach people. And people don't tend to be so frustrated and angry and mean, versus if it's a won't. I know you can do this behavior, but you won't give it to me. People tend to be very judgmental. So we talk about drilling it down. And we start with collaborative problem solving, which is basically the belief that people will do well, want to do well in their life if they can. Nobody really wants to be in trouble with a teacher or with a parent. We all want to do our best, but if we can't do it, then we need some support doing it. So basically, it's the lens of what we bring to the brain injury as healthcare providers in how we help people get through this. Are we teaching a new skill? Knowing what we know about these, the people, our patients or clients that we're working with, what else do they bring to this? They bring trauma to it. They bring depression to it. They bring other things. All of these things we have to kind of work through and have a different lens as we're going through it. So I think we're very close to time, and I'll stop on that slide, which is just an easy slide of can't versus won't, which reinforces, how your healthcare provider sees this as a can't, then they'll help you get interventions and treatment. If they see it as a won't, then it tends to be much more punitive and disciplinary.
Yeah, that's all of this hits on over and over things that are I think problems that almost every brain injured person has dealt with. And I like how you use the word lens, because there's not one lens but multiple lenses to think about this. That's missing drastically. And okay, so what Dr. McAvoy shares in this presentation, I think is an excellent model for thinking about and making sense of both brain injury, the nature of this kind of injury, and also the crux of the misunderstanding that comes with brain injury. So I just wanted to share a few thoughts here. So I use the term core problems, and when I say that term core problems, what I mean is that these are the internal problems that are underneath the other problems. They're underneath what the outside world sees. And in Karen's model, she has this pyramid with the different levels of problems that can be underneath. And she has a very clear, leveling that is based on some interesting data. And in my experience and my observation with other people with brain injury, the core problems that we have are very hard to deal with, but they're clear and they're clear to us. The problem is that the outside world often doesn't understand what we're dealing with. So I just wanted to say that I completely agree with the idea of this pyramid and this pyramid structure, and also the idea that these problems that are underneath, they need to be dealt with. They don't fix themselves. When you have a brain injury and these parts of you are injured, it takes a tremendous amount of work and repetition and focus to slowly restore these different problems. And the outside world really doesn't see that these problems are injured. They just see the outside, the end result, like you cannot function or you cannot do what was once automatic. And That's a very hard problem to deal with when you have a brain injury. And I would add that although I fully agree with this model and this pyramid sort of stratification, I would just add that I think that there are other layers that can be added to the pyramid, and I think that for each box there can be a depth of problems that can happen that may be unique for different individuals, and the depth of problems within one of those brackets. Like I had a problem with learning, but it wasn't just learning, it was a problem of getting information into my head and the gears of thought actually coming back. And I've spoken to many different brain injured people that have these different blocks that make up the pyramid as injured. And, that's the kind of stuff that I get into in my podcast. So I would just add that there are other layers to add to this pyramid. And, for me, I'm sitting here trying to focus on this in theory and focus on the ideas to share, you know, uh, to share the ideas and to promote a general understanding. But what Karen McAvoy is doing, and at her clinic, what they're doing is they're actually applying this. They're applying, this model towards helping people, towards focusing on what a person needs to improve, and then getting into the recovery. And that's a tremendous thing that I think is drastically missing. Having this kind of model is both it's essential for having a way to approach this for people, a way to help them make sense of it, and then also to get you into the right rehabilitation. So I think that's really an amazing thing. And most clinicians that I have met that focus on brain injury don't really have this model, or they're missing these essential pieces. And I think that's a big problem. Another thing that I wanted to add that comes up in this discussion and this presentation, and in the next part 2, where it's the Q&A, the discussion, this point comes up even more. Karen says that she takes people with brain injury at their word, and what that means is, she takes them at their word, meaning when you have a brain injury and you're trying to explain what you're dealing with, I think for the most part, and I know from my experience and many people that I've met, we have an accurate awareness of what we're dealing with. The problem is that we don't really understand what has happened, and often that part is very, very hard to make sense of. But we are accurate, we are aware, we are able to have a grasp of what is broken in us, what is not working in us. The problem is that when you explain it to people, they have no idea how to understand what you're talking about, and then people start to misjudge, misunderstand. They don't respect what you have to say, and they think of it as, oh, this is mental illness, or this person is crazy, or they're really, I guess there's a model from other mental illnesses that we are inaccurate in our understanding of what has happened to us, when I think that taking a brain injured person at their word is far more accurate. And although I know that the awareness itself can be injured, and I have met people with that problem, most of the time we are aware of what's happened to us and we should be taken at our word. It is the outside world's awareness of what has happened to us that is missing. And on that note, the she ended the talk with this idea of can't versus won't. And the won't is an idea of misunderstanding, misjudgment, and people think that you're unable to do something because you don't want to, or because you're lying, or because you're malingering, or because you have some other, I don't even know what the motivation is, but they interpret it as an inability because of a lack of desire or a won't, when in fact you can't. I use the term capacity a lot, and I think that with brain injury, you literally lose, injure, break, or unable to harness these very basic capacities inside of yourself that were once automatic. And the fact that people don't understand that, so you're left with both the inability to do it from the brain injury, and then the misjudgment and misunderstanding on top of that from the outside world. And it's a very, very hard problem to deal with. It's a very hard situation to be stuck in. And so, yeah, her example of can't versus won't, I think it extends drastically to other ways of looking at the misunderstanding that comes with brain injury. So, in the next part of this talk, part 2, it takes place directly after this presentation. It begins with Q&A and discussion that comes up, and a lot of other examples of misunderstanding, and just a lot of other problems with brain injury come up in that. So please share this talk with anyone you think that it may help towards understanding brain injury, making better sense of it, or understanding what people with brain injury are dealing with. And also, please check out my podcast, the Experiencing My Brain podcast. It's where I get into detailed discussion with brain injured people about these kinds of problems.